Good morning. I'm Dr. Melissa Arbuckle. I'm the Vice Chair for Education, and it's really my pleasure to welcome you to today's Grand Rounds. Today's Grand Rounds is really a special event in honor of Dr. Robert Spitzer, and we're going to start. Janet Williams is going to make a few comments.
Hi, everybody. It's wonderful to be back here, see so many old friends. I was here for about 40 years in the Department of Biometrics working with Bob, so I know many of you, and I'm really happy to see you come back. Thanks for supporting this lecture. I want to introduce Dan Spitzer, who's Bob's oldest son, who was unable to come last year. Dan's a professional musician, and he had a concert last year, so we're happy he's here. And also to let you know that 3 days ago, Bob's 5th grandchild was born, my first grandchild. And his name is Leo Raj Spitzer Williams. So Bob's middle name was Leopold. So the Leo honors him, and the Raj honors his mother's father. So we're very happy. He's a preemie, so he'll be in the hospital for a while, but he has a lusty cry, and he seems to be a fighter, so we're really happy about that. So this is the second memorial lecture in honor of Bob. It's supported by donations that many of you have made, and I appreciate that, and I certainly appreciate your coming too. We're not sure if there's enough money for another one or not, but I think this one will be really great, and I hope to be able to come back, if not for another lecture, to see many of you again under some other guise. So with that, let me turn it over to Michael first. And again, thank you for coming.
So good morning. Thanks again, everyone, for attending this special Grand Rounds. I'm going to start. I know a lot of you knew Bob personally, so this will be superfluous. But there are people here, I'm sure, don't know who Bob Spitzer was. So I think I'd start this presentation with a brief summary overview of some of his accomplishments in Bob's life. So Bob received a bachelor's degree in psychology from Cornell University in 1953 and a medical degree from NYU School of Medicine in 1957. He completed his psychiatric residency right here at New York State Psychiatric Institute in 1961, and of course was a fixture at PI for many, many, many years until his passing a couple of years ago. He graduated from the Columbia Center for Psychoanalytic Training and Research, which, given Bob's uneasy relationship with psychoanalysis, is a very interesting, though that was a time where everybody graduated from that institute. But Bob was, in fact, an analyst prior to his subsequent work in nosology. And he was also a member of the faculty of the Columbia University Department of Psychiatry and the Biometrics Research Department at the New York State Psychiatric Institute for over half a century. And he actually retired from Columbia in 2003. I would say, and I think most people would agree, that the seminal achievement of his career was the establishment of a psychiatric diagnostic system that was empirically based on uniform standards. Psychiatry, back in the 70s, was at a crisis of credibility when Bob Spitzer was asked to oversee an update of the American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders. Two studies published in the early 1970s shook the medical community's confidence in psychiatric diagnosis. In 1972, researchers compared diagnostic practices between clinicians in New York and London and found that the same patients who were diagnosed as having schizophrenia in New York were being diagnosed as having manic depressive disorders in London. And Bob Spitzer was a member of the steering committee for this study. The following year, Daniel Rosenhan, a psychologist, published a controversial paper in Science describing how 8 pseudo-patients were admitted to psychiatric wards for an average of 19 days, despite behaving as normal after a single initial claim of hearing a voice. Bob wrote a scathing critique of this experiment and, quote, "A careful examination of the study's methods, results, and conclusions leads me to a diagnosis of, quote, logic in remission, but recognized that both the reliability and validity of psychiatric diagnosis was rightfully being questioned." So this is a typical, Bob always was good with the turn of phrase. That was one of his many, many talents. Bob had devoted his early research career to developing questionnaires and interviews to measure psychopathology, culminating in the development in 1978 with the research diagnostic criteria and its companion interview, the Schedule for Affective Disorders and Schizophrenia, known as the SADS. Another talent of Bob was coming up with the great acronym, like the SCID's another one. Bob's exceptional intellectual, organizational, editorial, and political skills were put to the test in the production of the DSM-3, which required the development of an operationalized diagnostic criteria for every disorder in psychiatry in the face of opposition by the then prevailing psychoanalytic community. A field trial which demonstrated that clinicians could use the DSM-3 diagnostic criteria to achieve good diagnostic reliability resulted in its widespread acceptance by both researchers and mental health practitioners in both the United States and around the world. Among the new diagnoses championed by Bob as part of the DSM-3 process was post-traumatic stress disorder, which was added in part as a response to its increased recognition of the psychological sequelae of combat exposure among veterans returning from the Vietnam War. Bob also played a major role in having homosexuality removed from the 1974 printing of DSM-2. After meeting with gay rights advocates in the early 1970s, he began re-examining homosexuality based on whether it caused any measurable distress. The issue was extremely contentious, but in 1973, he engineered a deal by which the diagnoses were replaced by, quote, sexual orientation disturbance to describe people whose sexual orientation, gay or straight, caused them distress, making it clear that sexual orientation in and of itself was not the grounds for a diagnosis of mental disorder, paving the way for the eventual societal acceptance of homosexuality as a normal variation. Other achievements included developing the structured clinical interview for DSM, known as the SCID, which has become the most widely structured structured diagnostic instrument used for research, and the patient health questionnaire, the PRIME-MD, that is now widely used in primary care medicine for the screening and diagnosis of depression and for monitoring response to treatment. So let me now talk about this year's lecture. So the Robert L. Spitzer Memorial Lecture is given annually to an individual who has been selected because of their contribution in the fields of nosology, classification, and assessment. This year's awardee is Dr. Geoffrey M. who has been the Senior Project Officer for the revision of the ICD-10 Mental and Behavioral Disorders in the Department of Mental Health and Substance Abuse of the World Health Organization since 2008, which essentially means that Jeff virtually single-handedly runs the ICD-11 revision process for the chapters on mental and behavioral disorders, sleep-wake disorders, and aspects of conditions related to sexual health, particularly sexual dysfunctions and gender incongruence. Moreover, in the context of developing a mechanism for conducting internet-based field trials for ICD-11, Jeff has established the WHO Global Clinical Practice Network, a unique resource that comprises more than 13,000 mental health professionals in 152 countries. Dr. Reed did his undergraduate and graduate training in psychology at the University of California, Los Angeles. He began his career as a researcher as the project manager for the psychosocial portion of the Los Angeles site of the multi-center AIDS cohort study, working with Dr. Shelley Taylor and Margaret Kemeny, and producing scientific articles that contributed substantially to knowledge about the relationship between psychosocial factors and HIV-related disease progression. Following 5 years as a member of the research faculty of the Department of Psychiatry and Biobehavioral Sciences at UCLA, Dr. Reed moved to Washington, D.C. to work at the American Psychological Association, where from 1995 to 2006, he served as Assistant Executive Director for Professional Development in the APA Practice Directorate. During this time, Dr. Reed was also a senior staff liaison to the Board of Professional Affairs and managed development of the practice guidelines at the APA. In 1999, he also started consulting with the World Health Organization related to the WHO's development of the International Classification of Functioning, which ultimately led to his being appointed as the senior manager of the ICD-11 revision process. In addition to his leadership in the area of international classification and nosology, Dr. Reed is a leader in the area of global mental health. He is a founder of the Center for Global Mental Health Research, which is a collaboration of the National Institute of Psychiatry, Mamón de Flores Munez, Mexico, the Faculty of Psychology in the National Autonomous University of Mexico, and the World Health Organization. The center works to develop scientific and clinical competencies to improve the identification and treatment of people in need of mental health services in low and middle income countries. Oops, sorry. Particularly Latin America, through the development of research and teaching initiatives with a special focus on interventions across the lifespan in psychotic affective anxiety and substance use disorders. He has received numerous awards, including the 2017 Outstanding International Psychologist Award from the Divisions of International Psychology, American Psychological Association. He is also a visiting professor and scientific co-director, along with Kathy Pike, of the Global Mental Health Program here at the Columbia University Medical Center. He has written over 160 papers, book chapters, and books. So I'd really like to welcome Dr. Reed. Before Jeff begins his presentation, I want to present him with a plaque commemorating today's lecture.
I'm the stand-in for the PI photographer.
Okay, yeah, sure, you'll be great.
Okay,
Thank you.
Okay, Jeff, thank you very much. Congratulations. And I look forward to your presentation.
Thank you very much. Thank you for being here. It's really, let's see, my presentation went away. I can remember this part. Oh, it's on the screen, okay. I'm just not seeing it. Okay. See if you guys there, so it's going to be a problem for me. Thank you very much for coming here today. It's really an astonishing honor for me to be mentioned in the same sentence with a giant in our field like Robert Spitzer, and also to have the honor to be introduced by my dear friend and colleague Michael First at this event. And you know, I would never have expected to be invited to do something like this here, and in honor of Professor Spitzer. I also want to thank my colleague Kathy Pike, who's given me an amazing opportunity to work here with people from Columbia, some of the most talented people that I've ever worked with in the area of global mental health, and has also become a dear friend, along with members of the International Advisory Board, some of whom are here, and thank you very much for your support and your presence. This kind of an event, it makes you think a little bit about history and about posterity, and usually that's not something that's so interesting to me. I'm usually very pragmatic and present-oriented and very, that was then, this is now, and, what are we going to do about it today? Which tends to be how people at WHO function. So I did think a lot on the occasion of this talk about what's the history and how do we get here to where we are, and what does it tell us about what we're doing about mental disorders and what we know about classification. So I thought it was interesting as I was doing the research and putting it together, and I hope you will as well. I'm trying to think about a way to talk to you about what is the ICD, because I think most people in the United States don't know. So I think the thing that probably you can relate to most immediately is that there's actually no such thing as DSM codes. So you think that you use DSM codes every day, but in fact you don't. That all of the DSM codes are taken from the International Classification of Diseases clinical modification, which is in the United States the only official coding system that's permitted under the Health Insurance Portability and Accountability Act. So you're required to use ICD-10 CM codes for Medicaid, for Medicare, for most insurance companies in order to receive payment. And this is the same coding system that is used by professionals in all other areas of medicine. And as you will know, the ICD-10 CM went into effect in the United States in 2015. So that's what people in the United States think is the ICD, but it isn't. I should go forward. Here, this is just an excerpt from the DSM, and it only has the titles and the code numbers, so I think I won't get in trouble. But here you have, you see different personality disorders, and you see there's two sets of numbers next to the personality disorders. And the first number that you see is actually the code from the ICD-9-CM, which was the clinical modification of the ICD that was in effect when the DSM-5 came out. And then the second number is the code from the ICD-10-CM, which is the current number. And so the DSM-5 came out in 2013, and they knew that ICD-10-CM was going to take effect. They weren't sure whether it was going to be 2014 or 2015, and finally they just published the DSM-5 and they put both codes in there, which makes it more obvious actually that DSM isn't really in control of the coding, because they had to put two sets of codes there. Notice also that the codes actually aren't in order. So you have F60.0, F60.1, F21. What is that doing in this series? This is because these codes, in turn, have to come from the ICD-10, which is the WHO system, and in the WHO system, schizotypal disorder is not a personality disorder. It's in the section of the ICD-10 on schizophrenia and other psychotic disorders, and so that's, the numbers don't match, but they have to still use the ICD-10 numbers. So, what's the ICD-10? The ICD-10 was adopted by the World Health Assembly, which is WHO's governing body, in 1990 and published by WHO in 1992. So we're talking about something that happened more than 25 years ago. It has been used in the United States to classify mortality data from death certificates since 1999. So again, that's 16 years before it was adopted in clinical systems. The code set that is provided by ICD-10 provides 14,000 codes, and the chapter on mental and behavioral disorders is actually the only part of the ICD-10 that has definitions in it. If you look at the other parts of the classification, you will see the category name and something that's called inclusion terms and exclusion terms, which is a set of references for coders about what should be included in a particular concept, but that's all. It's just a list of categories, but mental and behavioral disorders is different than that by having the definitions. There are updates published by WHO of the ICD-10 every 2 years. And so here's what the ICD-10 actually looks like. You can access it online. This is the 2016 version. It's free. There are print versions available. That's also the 2016 version. And this is the WHO classification system. The clinical modification is an adaptation of the ICD-10 that was done by the National Center for Health Statistics that is now part of the CDC and the Centers for Medicare and Medicaid Services. Partly what the difference between the ICD-10 and the ICD-10-CM is the addition of some additional kinds of codes that hospitals need for medical records. But in addition to that, there's a lot of other information that provides more detailed coding than exists in the ICD-10. So, for example, in the ICD-10, you have this E08.11, which is diabetes mellitus with ketoacidosis, but they don't have with coma and without coma. So in ICD-10-CM, they thought it was important to add with coma and without coma because, I think you could imagine that this would be because it would be related to the treatment and the authorization for charges for this particular condition, et cetera. So this is the ICD-10-CM. It's available on this page. You can also get it free. You can download the whole thing. What you will find is basically a list of codes, like for most of the ICD. In the ICD-10-CM, Michael, do the mental disorders have definitions or no, it's just codes? Okay. So all the codes that you would need legally to be able to submit, any of your bills that you want can be found actually on this website. And this is what they use to put into the DSM. So why does the World Health Organization do the ICD? I will talk about this more in a couple of minutes, but the World Health Organization was founded after World War II in this sort of surge of international hope and was given a set of constitutional responsibilities that corresponded to its core activities. So you can find the WHO Constitution online, and it's surprisingly interesting. I I should read this because really I work in this organization. I thought it would be some terrible legislative thing that would just go on for pages and pages. It's short, and it's actually pretty clear, and it's surprising in the clarity with which it delegates authority to WHO for a set of international public health activities. And there are about 30 specific activities that are listed in the beginning of the Constitution, and these are referred to at WHO as WHO's core constitutional responsibilities. And two of them are these: to develop and maintain international classification systems for health and to standardize diagnostic procedures as necessary. And then when countries become members of the World Health Organization, member states, and there are 194 member states, including the United States, they accept particular obligations. And one of the obligations that they accept is to use the ICD, WHO's ICD, as a framework for the collection and reporting of health information. So you can see that it is embedded into the fabric of WHO. It's not something that WHO has an option about. It's part of WHO's constitution. And it wouldn't be something that we could say, okay, well, somebody else is going to do this now, we're tired of it. So why do countries use the ICD? I mentioned that they use it as a framework for health information and reporting. That's actually the only obligation that's created for them by the ICD is to report health statistics to WHO using the ICD. As a framework. And so that gets used then to monitor and track mortality, morbidity, epidemics, threats to health, disease burden. Obviously, if you don't have the same idea of what is cholera in Mexico that you do in South Africa, it's going to be hard to keep international statistics. They also are, these statistics also then get used as a mechanism for assuring a kind of accountability among member states for the health status of their populations. Increasingly, though, and I think this is really where the rubber is meeting the road in today's system, they get used as a way to define the obligations and those of other parties to provide free or subsidized health services to their populations. So what I mean by that is that if you live in Germany, your right to receive a particular set of health services depends on your having a particular diagnosis. And if you don't have a diagnosis, it's kind of like, okay, well, you're not sick, why are you in my office? And similarly here, even though you don't have single payer health care, if you don't have a health condition that corresponds to a particular set of services, then you won't be authorized to provide those services. And so countries have integrated classification much more strongly into their legislation and their policy than was the case originally. And so it's really become something that's quite different than just a statistical framework. That was really, to be fair, is part of why it took the United States 25 years to implement the ICD, to figure that out, and changing the information systems, et cetera, et cetera. There would be an argument that they should have just skipped ICD-10 and gone to ICD-11, but that's a conversation for another day. So we hope that the ICD then will facilitate access to appropriate health services, that it becomes a basis for guidelines for care and standards of practice. Most guidelines, most standards of care are based on diagnosis as the organizing principle, and ultimately to facilitate research into more effective treatments and prevention strategies. Meanwhile, while all this is going on, while you're thinking about implementing the ICD-10, then implementing the ICD-10, then complaining about the ICD-10 in the United States, WHO has been developing the ICD-11, and this has been going on now for the past 10 years. And so in the mental and behavioral disorders chapter is the part of it that I am coordinating. Ultimately, it was supposed to be 2 people, I will tell you. There was meant to be another person besides me. I wasn't going to do it all by myself, but they decided after a while that they really didn't have the money for the other position. So it ended up just being me. So it is what it is. So we are almost toward the end of this process. The text for the ICD-10, the ICD-11 clinical descriptions and diagnostic guidelines will be finished by the beginning of next year. It will be sent to WHO Press. It will be sent through all the sort of elaborate political clearance that it has to have, and we expect that it will come out in the summer of 2018. We are currently involved in doing field studies. Some of you may be members of the Global Clinical Practice Network, and if you are, you get invited from time to time to do to participate in our internet-based field studies. There are also a particular kind of clinical field studies happening here at Columbia. Maybe some of you are participating in those that involve assessing the clinical utility of the diagnostic guidelines. We have studies like that all over the world right now. Based on those studies, we will be revising the ICD-11 and finalizing it, as I said, by the beginning of next year. WHO publishes 3 versions of the mental and behavioral disorders besides the statistical version that's used by coders and health statistics departments in countries. One of them is a really simplified version for primary care. The middle one, the blue one, is designed for mental health professionals to use in clinical settings, and the green one on the right is the diagnostic criteria for research, which if you look at the ICD-10 diagnostic criteria for research and the DSM-4 side by side, you will find that they're quite similar to one another, and I'll say a little bit more about why that is. When we think about, this is just to point out that WHO's constituency is very broad. 80% of the people in the world live in low and middle income countries. You know, most of the people in the world who have mental disorders will never see a psychiatrist in their lives. So we have to have systems that are usable by the people that are in those kind of systems. So, you know, 450 categories or however many it is, I haven't actually counted, is really too much for that to be an expectation. So this primary care version is the 28 categories that were considered to be most important for primary care professionals to be able to recognize, et cetera. The research version is more complicated. You clearly need a version that you make into so that it's entirely closed-ended, so you can do epidemiological studies, and there are various reasons why you would have particular kinds of research presentations, and Michael and I are very involved in working on that going forward. I don't think we're gonna see one product related to that. There will be different research versions for different purposes. It's hard to imagine that the DSM wouldn't be the most used system in clinical settings around the world, or really the only system in clinical settings around the world, but it isn't. This is not epi-data, so I'm not saying this is representative, but this is an example of a study that we did in 44 countries of almost 5,000 psychiatrists, and the question is, what is the diagnostic system that you use most in your day-to-day clinical practice? And you can see that a little over 70% of them said that they were using the ICD-10 in daily practice. We did look at that in more detail, and we found that it wasn't just that they were using it for billing. It was that they were actually using the diagnostic guidelines in similar ways that people use the DSM diagnostic guidelines here. So, how do we understand the place where we are now? That there seems to be these 2 systems that are somewhat related to one another, but you have to use the same codes, but then the US modifies them, and they're somewhat independent from one another. And I thought, actually, in understanding that I wanted to really go back to the beginning and think about, you know, how do we get here? What is the purpose of classification? And it was quite interesting for me because I think in many ways the history of classification is the history of public health. And so that's the place where I started. This is an image from the London Bills of Mortality, which represented, usually most accounts would identify this as the first systematic attempt at population-based classification of illness. So it began actually in 1592. These are summaries of mortality statistics based on the monitoring of burials. A couple things to notice here. First, the classification was done post-mortem. And second, the pressing public health question at the time was, why do people die? It's not, why are people sick? We're not quite there yet. And you can see in this image on the right that of the 5,319 people buried in this particular week, 3,880 of them, nearly 3/4, had died of plague. Then you see some other causes of death, like frighted, griping in the guts, and found dead in the street at St. Bartholomew the Less. So there's not really any kind of consistent terminology. There's not really a reflection of an understanding of what are the causes of death or the causes of disease, but it's impressively systematic, I think, for something that was happening at the end of the 16th century. And to me, I know Bob Remian will remember this. It looks a lot like the way the Morbidity and Mortality Weekly Reports from CDC used to look. It's basically the same thing. And unfortunately, I was looking at these a lot when I was doing HIV research, and Bob was in the New York part of that same project that Michael mentioned, and we used to look at these reports quite a bit. Unfortunately for me, I don't do that anymore, but I think they clearly have the exact same function. The next thing that you hear about a lot in connection with the history of classification is William Cullen, who released this classification of diseases in 1789. I'm not going to try to pronounce the Latin names. I slept that day in class. But he had 4 major groupings of disorders: febrile diseases, neurosis or nervous diseases, diseases arising from bad bodily habits, and local diseases. So the system was based on observable symptoms considered to arise from each disease that were then used for the diagnosis. So 2 things jump out at me for that. One is that the important role of mental and behavioral disorders, because it's really half the system, right? You have the neuroses or nervous diseases, and then you have the diseases arising from bad habits. And also that the idea of an empirical classification of disorders based on observable symptoms is not really such a new idea. The next place that the story tends to go is to William Farr, who is clearly one of the great heroes in the story of classification. He was the first ever medical statistician in the General Register Office of England and Wales in 1938. And he comes into our story for ICD in 1839, first of all. This was part of his first yearly report. He said, the advantages of a uniform statistical nomenclature, however imperfect, are so obvious that it is surprising no attention has been paid to its enforcement in bills of mortality. So you see he's still using the London Bills of Mortality as the basis for his efforts. And then he talks about how the terminology is really consistent, it's inconsistent, it's vague, several terms are used for the same thing. And he says, but the nomenclature is of much importance in this department of inquiry as weights and measures in the physical sciences and should be settled without delay. So he was really excited about the standardization or the need for standardization of terminology, which would be used for the classification of mortality. He went, presumably as part of his job, to this first International Statistical Congress that was held in Brussels in 1853. And he and Marc Despeen from Geneva were asked to prepare an internationally applicable uniform classification of causes of death. At this point, Marc Despeen kind of disappears from the story, and you never hear from him again in anything that I read. But probably Ezra knows what happened to him. But Farr ended up proposing a system of classification of diseases that classified them by anatomical site, which is basically still what we do. 40 years later, his classification provided a lot of the basis for what became the International Classification of Causes of Death. It sometimes gets called the Bertillon classification because it was developed by a committee chaired by Jacques Bertillon, who was the chief of statistical services in Paris. It was then adopted by the American Public Health Association in 1898, and then in 1899 was formally adopted by the Institute of International Statistics, which then became what's considered to be the first ICD. It was the first internationally accepted classification of mortality. But we would think about it really as ICD 0 because the ICDs are actually numbered by the revision. So ICD 1 is first revision. So it's the 11th version. ICD 10 is the 10th revision, the 11th version. Anyway. So then the government of France took over sponsoring them and hosting the meeting, and they had these meetings about every 10 years to come up with new versions of the International Classification of Causes of Death. At the 5th meeting in 1938, they talked about, really, we need to integrate morbidity into this classification. It can't just be about mortality. And so that work was taken forward by the U.S. Committee on Joint Causes of Death, also working with Canada, the UK, and the League of Nations, which was sort of the predecessor to the United Nations. And they ended up proposing something that was called the Statistical Classification of Diseases, Injuries, and Causes of Death. At that point, then there was World War II, right? So that was kind of a distraction. And then after that, the United Nations was formed, and WHO was chartered as a specialized agency of the United Nations. So they had this thing called the Interim Commission on the World Health Organization, and they were busy deciding what would the responsibilities of the World Health Organization be. They decided that one of the things that they would assign to WHO, as I said, as a core responsibility, was the responsibility for maintaining the classification. So the Interim Commission was asked to prepare the next version of the International List of Causes of Death and also to establish an international list of causes of morbidity. So then out of that came the International Classification of Diseases, Injuries, and Causes of Death, which we think about as the ICD-6. It was the first version of the ICD actually be published by WHO, because WHO didn't exist before that. And it was the first version to include a classification of morbidity as well as mortality, and the first version to include a classification of mental disorders. When it was approved, they said all kinds of grand and sweeping things about what it meant. They said that it marked the beginning of a new era in international vital and health statistics, the adoption of a comprehensive program of international cooperation. Governments were urged to establish national committees on vital and health statistics. We still have that committee in the United States. It's still actually pretty important, the National Committee on Vital and Health Statistics. And those committees, one of the things that they were to do is to serve as a linkage with WHO. So this National Committee on Vital and Health Statistics actually works with the National Center for Health Statistics. The idea was that they would work either on problems of national importance or they would collaborate with other national committees to look at things internationally, and they would report all of their interesting findings to WHO. So this kind of narrative places the ICD in this classification, this very historical kind of grand narrative of all these things that happened going back to 1592, these interesting people like William Farr and William Cullen. So then you can ask in that context, so why do we have the DSM, right? And it turns out that there's another story about the DSM, right? So in 1840 in the United States, the US Census started to collect information on idiocy or insanity. That was what it's called. I'm not trying to be insulting. That's what was on the form. And then other classifications in the late 19th century were developed to document the diagnostic status of the large populations of people in psychiatric hospitals. What was called then the American Medico-Psychological Association, which is the same organization that we now call the American Psychiatric Association, became involved in those efforts in 1917, publishing the Statistical Manual for the Use of Institutions of the Insane in 1918. So you see there's this very long history of the APA in efforts around classification of mental disorders well before WHO even existed. By the 10th version, that classification had evolved into something called the Statistical Manual for the Use of Hospitals of Mental Disease. The Army, the US Army, needed something different that wasn't so institutionally focused to classify people's mental health in the context of the Army. They developed their own mental disorders classification that was called Medical 203 during World War II, which was later adapted by the Veterans Administration as the Nomenclature of Psychiatric Disorders and Reactions. So when APA published the first version of the DSM in 1952, this was heavily influenced by these predecessor US systems, but also by the ICD-6, because APA had actually been represented on the committees that developed the ICD-6. And so when ICD-6 and DSM-1 came out, although it wasn't called DSM-1 at the time, that's when the histories became intertwined, and the sort of fates of the American Psychiatric Association and the WHO became linked in a particular way. It takes a lot to actually find this information. If you want to figure out kind of both sides of the story, you can't find it in any one source, because both stories are told in a very one-sided way. If you look at the information that's about the American Psychiatric Association and the DSM. It hardly mentions WHO at all. It's just all about, we've been doing this since 1917, and I told you the WHO narrative, right? It also doesn't mention the American Psychiatric Association. So you have to really do some digging to figure out how did this actually happen. It's clear that both WHO and APA have a legitimate claim to the historical foundations of modern classification in some kind of important way. So it's not just that one party should just stop it and go home. So what happened then? Most of the ICD-6 and the mental disorders classification in ICD-7 was actually the same as ICD-6. It was well received, widely adopted around the world, except the section on mental disorders. By the 1950s, the section on mental disorders wasn't really being used by anybody. It was like 5 countries. It was like the UK and Canada and something like, it was just a scattering of countries that's not really a natural group. The WHO commissioned a psychiatrist named Erwin Stengel to provide a report investigating why people weren't using the classification, what was the problem with it. His 1959 report indicated the description needed to be separated from theory, and he emphasized the need for explicit operational definitions of each category as a means of promoting reliable clinical diagnosis. So the report is actually pretty long, and it's very spirited, and he's arguing passionately about how this should happen. But in 1959, he's putting forward a very strong argument for something that was only realized, instrumentally with the involvement of Robert Spitzer much later. Actually, immediately everybody pretty much ignored him. So what happened after that was that you had ICD-8, is that right? Yeah, and DSM-2, and then this is out of the preface to the DSM-2. It says, this second edition of the Diagnostic and Statistical Manual of Mental Disorders reflects the growth of the concept that the people of all nations live in one world. Imagine that. With the increasing success of the World Health Organization in promoting its uniform international classification of disease, already used in many countries, the time came for psychiatrists in the United States to collaborate in preparing and using the new 8th revision of that classification as approved by WHO in 1966 to become effective in 1968. The rapid integration of psychiatry with the rest of medicine also helped create a need to have psychiatric nomenclature and classifications closely integrated with those of other medical practitioners. So DSM-2 and ICD-8 are essentially the same. There are some minor variations, but they're quite minor. So this really, I would say, is the high watermark of ICD-DSM harmonization. This was really where it intentionally reached its maximum. And imagine who was on the committee that produced the DSM-2. There you have a name that I've highlighted in orange, and these other revolutionaries who were talking about, the United States being part of the world and the need for psychiatry to, work with the WHO. According to the recommendations of Stengel, there were several efforts, Michael referred to some of these, that happened to further operationalize psychiatric diagnoses. After that, the Feiner criteria were published in 1972. Then WHO published a glossary of terms, which was basically an attempt to produce operational definitions for all of the diagnostic concepts and other important terms. The WHO glossary was developed through a kind of international consensus process, and they tried to really base it on descriptive operational criteria. Then the Feiner criteria were expanded to the research diagnostic criteria with Dr. Spitzer's involvement and leadership, as Michael mentioned earlier. So then what happened? One of the key players, obviously, as I mentioned in the RDC, was Robert Spitzer, which is not coincidentally the second of 2 photos that I have in my talk today. And he was, I'm not sure if he was asked to lead or he assumed the leadership of the DSM-3 efforts, probably a little bit of both things, yeah? I get that he was a pretty strong personality. Unfortunately, I never got to meet him, but you hear stories. An early decision that confronted the authors of DSM-3 was whether to follow the DSM-2 approach and kowtow to the global hierarchy or to go in a different direction. And according to Spitzer in 2001 piece, the DSM-3 committee believed that despite the value of a single international classification system, it was more important that psychiatric classification benefit from new developments in American psychiatry, such as the development of diagnostic criteria. And he acknowledged that it was true that psychiatrists would have to use codes from the ICD-9, but we are relatively unconcerned by frequently having a different definition of a DSM category than a corresponding ICD-9 CM category. We believed it was a small price to pay for our ability to be innovative. This is why people from other countries hate us. It's not unusual for somebody from the United States to have this idea that, but if you think about it as a management task, it was so innovative, it was so intense. I mean, you hear these stories about, these people locked in a room for the entire day and, Bob at a typewriter typing out the criteria while these people were talking around him. The idea that you would do that on an international basis, it seems like it couldn't have happened. So I think, partly this was a rationale for carving up the work into a manner that could actually be accomplished. So what happened after DSM-3 was much more fully realized, this operational approach, than any previous classification. It was quickly accepted by the field. It became the standard for research funded by US federal agencies, particularly NIMH, and for the testing of new drugs for approval and regulation by the FDA. It produced, after its adoption, a proliferation of new findings on mental disorder prevalence. It became a basis for epidemiology that hadn't really existed before, course of illness, genetics, many other areas. So it was really, I think accurately conceived of as a revolution in psychiatric diagnosis, even though obviously it had predecessor events, as I've said. So once that happened, you would think that there would be some space then for harmonization. Okay, Bob, you've proved your point. Now let's come back to the ICD and try to make something that the whole world can adopt based on the work that you've done. And so both WHO and APA stated that for purposes of international communication and collaborative research, both classifications, differences between the classifications should be minimized. So there was a lot of collaboration. It was sponsored by Adam Ha, which was I don't know the acronym, it's a mental health and drug abuse something. So they had a bunch of meetings between ICD people and ICD 10 people and DSM-4 people. They had work group meetings, work group members meet face-to-face. The ICD-10 criteria sets were included as alternative to be tested in the DSM-4 process. So it was really a pretty serious effort to achieve some degree of international harmonization, even though there was no particular obligation on either side to do what the other side had decided. Part of what enabled this kind of interchange was a copyright agreement between WHO and APA, which I actually have seen. I have it. And it essentially allows both organizations to use the other's material as a part of the development of their particular system. So, it says APA hereby grants WHO permission for such use and agrees that it will not bring an infringement action against WHO or against other entities publishing with the permission of WHO. And it says, regarding contributions of WHO to the APA that are drawn from parts of the ICD-10 relevant to psychiatry, its coding numbers, and its derivative works, WHO hereby grants the APA permission for such use. So it's quite sweeping, it's quite broad. It's like you have permission to do what you like. And it did enable a kind of an interchange at that level that really might have continued. Nevertheless, Michael did a systematic analysis of the differences between the DSM-4 and the research diagnostic criteria for ICD-10, which is going to be the version that's the most like DSM-4. And only one of disorders, transient tic disorder, which we use a lot, was identical. 21% were considered to have conceptual differences. and 78% had differences reflecting different ways of operationalize the same diagnostic construct. They were clearly talking about the same thing, but they talked about it in a different way. This was an article in British Journal in 2009. As we began to work on ICD-11 and DSM-5, because the periods of time during which we were doing the work were substantially overlapping. DSM-5 started earlier than us, but we've taken longer. So there was a period of several years where both systems were under development at the same time. So many ICD-11 working groups included individuals on ICD-11, I should say on DSM-5 committees, so there were common members, usually a couple of them. The ICD-11 working group charge included this to review DSM-5 proposals and consider how these may or may not be suitable for global applications. There was no requirement given to the working groups that their proposals couldn't deviate from what it said in DSM-5 or what at that time had been proposed for DSM-5 because it wasn't published yet. But if they were choosing to make something different from DSM-5, they needed to be able to explain why they were making that recommendation. So this was something that Michael and I actually particularly enforced. There was an attempt not to have what has been called in the WHO context frozen accidents of history that were just kind of random differences between the ICD-11 and the DSM-5. There was a harmonization committee that met several times. It ended up focusing quite a bit on the organization of categories, what gets called the metastructure. So the ordering of the categories in ICD-11 and DSM-5 is largely the same. So the groupings follow the same order. I mean, I think that's in some ways the major achievement of the ICD-11 DSM-5 harmonization meeting. There was an idea that there would be a similar copyright agreement to the one that we'd had with ICD-9 and DSM-4. But despite multiple meetings and discussions, WHO could not agree on a copyright agreement allowing the organizations to use each other's materials because of APA's concerns about copyright protection and intellectual property. This is just true, right? I mean, we just couldn't, and you probably understand how APA is about the copyright with DSM. There just wasn't a circumstance under which WHO would grant APA enough prohibitions against what WHO could do with the material that would be acceptable to WHO. And APA was afraid that its material then given to WHO would be, released to the entire world without any kind of financial benefit or ownership. So it didn't happen. I mean, some slightly unpleasant meetings, and then we kind of gave up the effort to do that. It's relevant here to point out that WHO has recently reaffirmed very clearly its publication policy from November 16th onwards. The Creative Commons Attribution Non-Commercial Share-alike license will progressively be applied to all WHO publications. License allows free reuse of published material, but is limited to non-commercial use and obliges users to license any derivative products under the same terms. So what that means is that if WHO has a publication, like the ICD-11 Clinical Descriptions and Diagnostic Guidelines, if you want to reprint it and give it away to people, you can. You don't have to ask people's permission. You don't have to ask WHO's permission. If it's a non-commercial use, it's automatically approved. If it's a commercial use, you do have to ask. So if you want to put a different cover on it and sell it, you have to get WHO's permission. WHO wouldn't give you permission to do that because they look at what's the value addition of your particular product compared to what they already have in making that decision. But the emphasis is very, very clearly on making the material available, which I have to say is, I get as an aspiration. I think it's the right ideal, but it does create some sort of mechanical difficulties, like what's then the revenue stream that supports distribution, and how do you offer training, and how do you develop related materials that people would be able to use. So sometimes we shoot ourselves in the foot a little bit by being so extreme in our public benefit positions, but I mean, that's obviously my personal opinion. It's not a formal position of WHO, but it is what it is. I mean, this is WHO's policy very clearly. So the other thing that happened really after DSM-3 that I think initially was a big surprise was this. This is a graph that I stole from Roger Blatchfield that was in an article that I did in Journal of Nervous and Mental Disorders in 1996. And so they used all the sources of information that they could and estimated the amount of money that had been generated by the DSM, different versions of the DSM, and then it was in 1996, so they projected the revenue from DSM-4, and here's what you see, that by DSM-4, they were projecting that it would be at the astronomical level of $30 million. I don't know what the actual figure was, but it was a lot more than $30 million. This is from APA Treasurer's report that somebody sent me one year, and it shows by year they're making $5-6 million. So it is a major source of revenue for the APA. This is not, again, I mean, if I were in that position, what would I do? I mean, I don't know. I mean, there might be, all of us might do the same thing. I mean, I don't think that it's entirely a commercial issue. I think that there is a sense among people who work with this closely that they're kind of protecting a sort of intellectual tradition that's really important, and that they're doing so on behalf of the world and on behalf of psychiatry, and that APA is somehow the custodian of this work. And so I don't think that's all fake. I think there is really that feeling about it, but I think it's really hard to separate from the financial situation. So when is the ICD-11 and the DSM going to, when is the ICD and the DSM going to be harmonized? When are we going to not have two systems anymore? On the 25th of never, right? I mean, it's going to be when WHO abandons its constitutional responsibility to maintain international classifications for health, or when the APA decides it doesn't need this money. So where does that leave us? Who suffers for this? Not you. It doesn't make any difference to you. You use the DSM here in the United States. You continue to use the DSM here in the United States. The National Center for Health Statistics will continue to try to figure out how you can use ICD codes as their charter requires while using the DSM. Those will continue to be printed in future editions of the ICD. I think for American mental health professionals, this actually has very little impact. I mean, you're sort of very vaguely aware that there's this ICD. You're not quite sure what it is. Is it ICD-10-CM? Is it the ICD-10? You don't know. So I mean, I think it doesn't matter that much to you, frankly, which is, one of the things that makes it hard to talk to U.S. audiences about. It matters to non-U.S. clinicians more, right? Because they sometimes get trained in the the DSM, and then their systems will require them to use the ICD. They have to sometimes be familiar with two diagnostic systems and go back and forth between them. They don't express so much distress about that, but it is a reality of their lives. And I think the DSM has done a much better job of creating educational materials for students, and partly because they sell them, but anyway, they exist. Those materials for DSM that you can use for training are there, and we don't really have those for the ICD. It's possible that these different diagnostic decisions based on which system you use would affect decisions about whether participants are included in studies. I don't buy that, right? Because if you're a researcher, you could decide to assess DSM and APA and ICD criteria and look at both in deciding on who is your patient population. But it could have to do with the allocation of treatment, the effectiveness of treatment, and judicial decisions could potentially be different in the United States and other parts of the world. Not that different judicial behavior in the United States has ever particularly bothered us here. I'm not sure really there's a lot of hand-wringing about this situation, like, oh my God, it's so awful that we have two things. But if you think about the practical effect, it's a little bit harder to identify what that would be. So I want to talk a little bit about what is the silver lining, I think. Consider the idea, and then I'll shut up, I promise. So consider the idea that mental disorders are latent constructs. And I know that last year, Ken Kendler talked about this issue, right? That latent constructs are variables that are not directly observed, but are rather inferred from other variables that are observed. That is, they're that can be directly measured. In a mathematical model, we are aware that all of the observed variables have error associated with them. So the error could come from just kind of random variation, or the error could come from some kind of systematic measurement bias. But we're inferring the characteristics of these latent variables based on observed traits or behaviors. So that's what criteria are, right? I mean, the criteria is not the disease. You know, what is depression? It's not 4 of these 9 things. It's something underneath that you're using these 9 things to try to get at. You're using these 9 things as observable manifestations of something that you're inferring is underneath. And each of the criteria then would also have error associated with their measurement, which we remember mathematically, but we don't tend to remember it when we're applying criteria. But the idea is that this is a kind of a regression equation, right? You're kind of trying to figure out the combination of indicators that gives you the most reliable ability to capture the latent construct that's underneath. So any of you that have PhDs in psychology, you saw this paper and cried at having to read it in graduate school, but it's Campbell and Fisk, 1959. It's Convergent and Discriminant Validation by the Multi-Trait, Multi-Method Matrix Psychological Bulletin. It's very long. So I'll tell you what it says. Basically what it says is that if you have only one way to measure something, there's no way to improve the validity of your measurement. You can't. And so that results in your measurement being reified, your measurement being then confused with what is the phenomenon that's being measured, and you have no way to improve the situation. I think if we look objectively at the iterations of classification that we've had since DSM-3, that we're somewhat in that kind of a situation. We keep refining the criteria, but we never have really an ability to be quite so, to step outside of it, to have another way to look at it that would really enable us to do this kind of validation work that we would require. So there's a whole bunch of publications that you can find. I took this out of a paper of mine from a few years ago, so you can find more modern ones that talk about this problem, that raise the issue of, do we really understand the basic phenomena that we're trying to measure? And I mean, I think we do. I think depression is a real thing. I think clinicians actually do know something. I believe that very strongly. But there is a question about, do we really understand the characteristics of the latent constructs that we're measuring with the criteria, or have the criteria somehow really run away and become their own entities and we're not really talking about what's underneath them anymore? And this is kind of, I think, what Hyman is saying about the problem of reification. It's what clearly Insel was saying when he introduced RDoC. This is the criticism, which you can find all over the place. So then I would say that maybe we need more than one way. And this is something that a very smart guy named Robert Kendall wrote in 1991. It's almost inevitable that the DSM classification of mental disorders differs from that of the WHO. ICD is a comprehensive classification of all diseases, et cetera, et cetera. The APA classification is designed to meet the needs of one or perhaps two professions in a single country. If there are differences, let them be substantial. That would at least provide the research community with a choice between two genuinely different alternatives. The worst outcome of all will be for the DSM-4, he's writing this in 1999, will be for the DSM-4 and the ICD-10 to be littered with trivial differences in phraseology and casual differences in the way in which different groups of disorders are subdivided and defined, none of which are rooted in important conceptual differences, which turns out is exactly what happened, because that was the paper that Michael did. So I would like to give you a couple of examples. We think we've avoided this trivial difference thing, and we have instituted some protections about that. Are there still some? Sure, but we have made a big change in being conscious about that. But here's some examples of where this could help us. So one example is the whole idea of criteria. So we have taken an approach to describing disorders that we would call more guidelines that are intended to be used by clinicians. And what we do with the guidelines is we say, what are the essential features of disorder? What are the things that a clinician could reasonably expect to see in all cases of disorder? They don't have these very precise algorithms. They don't say you have to have 3 of these 9 things and 3 of these other 9 things. They describe what is the characteristic, what is it inattention fundamentally? What are we trying to talk about? What are we trying to talk about when we talk about hyperactivity? And they don't say, okay, go home and come back next week if you only had it for 3 weeks. Because some of the people that we're dealing with are people who say, if I'm seeing this patient, I'm the only health provider that this patient is probably going to see that year. So I can't send the patient home, saying, come back when you have one more symptom, or when you have, when you've gone over the threshold. It has to be, which is, reasonably how clinicians behave. I mean, nobody actually does what I'm saying, but the criteria kind of pretends like they should. So it would be important to know, this is intended to support a more flexible exercise of clinical judgment that assumes that clinicians are thinking beings that use these criteria or these descriptions in an intelligent way. It would be important to know if that produces less reliable diagnostic outcomes than a more controlled, tightly structured approach. So here's an example. This is the essential features for PTSD. It basically consists of 3 things. You have to have an event, so that's part of it. So an event that you experienced as horrific or extremely frightening. You have to have re-experiencing, and there are different ways to have re-experiencing. It's not just flashbacks, which is a characterization I see in the literature some, but it's just actually wrong. But it's a confusion of whether something is happening in the here and now, either emotionally or cognitively, or in terms of its sensory characteristics, and whether it's a memory. So it's not just remembering something that's bad that happened to you. It's the feeling that it's happening again. Deliberate avoidance of reminders and persistent perceptions of heightened current threat causing significant impairment. Yeah, so that's very different from what we see for. I had a slide in there. For DSM, right? So this was a kind of snarky paper that was written by Richard Bryant, and I think one of his students, that was 6,036, 120 ways to have post-traumatic stress disorder in DSM-5. It's making a point, yeah? I mean, it's not really doing a very good job of focusing on what are the essential dimensions. ICD has also included complex PTSD, and there are a lot of controversies about that. It includes the same core features of PTSD, but also severe and pervasive problems in affect regulation, persistent beliefs about oneself as diminished, and persistent difficulties in sustaining relationships. I'm going to go back to the slide I skipped in a minute, but the ICD-11 PTSD proposals were published in a couple of widely circulated publications. There was in Lancet, it was in World Psychiatry. Since then, there's been a really spirited debate about the essential nature of PTSD, and is complex PTSD a real thing? And there's been a large number of secondary data analyses and increasingly new data collections. And I looked today, and there are 77 articles in PubMed that have come out since the ICD-11 diagnostic guidelines were described that look at this question. This can't be a bad thing for the field, right? And so it would be arrogant to assume that we already knew what was the essential nature of PTSD, and we didn't have to do any of this investigation. So I don't think it's really a disaster. Now, the question that I asked before about are these kind of descriptions inherently less reliable than more criteria-based descriptions? These are preliminary data from some of our reliability field studies that I'm showing you because we're talking about it in Berlin next week, so we're already talking about it a little bit, even though I don't love talking about preliminary data. These are only the English data. It's a very different methodology than the DSM field studies use. This is joint reliability testing. You would expect that you get much higher CAPAs from this methodology than from the DSM methodology, but still, they're 0.8, except for the things that are harder, like acute and transient psychotic disorder and bipolar 2. So these are very solid reliability. So you can't really say, I think, accurately, and this will be a discussion that we continue to have for a while, that not using clear, strict operational criteria gives you less reliable diagnoses, because clinicians don't apply them. They think about the gestalt, they think about what is it, and so you should try to communicate to them what is the meaning of what you're asking them to diagnose, what is the principle that you're being asked to evaluate. This is how I was trained, and I would imagine most of you. So you don't need to tell me if it's 3.5 weeks or 4 weeks, or if it's 4 or 5. Another area that I think is a good example is personality disorders. I won't take the time to go through this all, but I will just summarize it, which is that DSM tried to move to a dimensional system of personality disorders. All hell broke loose. There was serious fights about it. The committee, people resigned and stormed off, and it was ugly. So then what happened? They kept the same system from DSM-4. DSM-5 in the main classification has the same system that DSM-4 did. There is in the back, in section 3, an alternative model that also looks like it was a product of intense negotiation, because it's a very uncomfortable kind of hybrid of categories and traits, which were what one party was really trying to advocate. Our group looked at that and said, too complicated. It's not really going to work for the global audience. So they developed a much more simple dimensional system that we think actually has a chance to be approved. I went to the International Society for the Study of Personality Disorders last week because they were ready to burn our houses down, because they were very upset that we were, getting rid of borderline and all the associated 50 years of research, and we had to agree actually to include a borderline qualifier in the system, but that I think doesn't destroy the conceptual integrity of the trait-based system. I think it'll be okay, and if that's what helps people to make a transition, if they need some way to get themselves from before to now, then whatever, it's fine. It's a small price to pay. So the last thing I want to say is here. I would like to come back to William Farr, because he played a small but pivotal role in the events that led to this discovery of the source of the devastating cholera epidemic in London in 1854. And therefore its transmission by contaminated water. The story is mostly about a young physician named John Snow, not the one from Game of Thrones, and a priest called Henry Whitehead. And the story is told in a very exciting and fascinating way by Stephen Johnson in his book, The Ghost Map, which was recommended to me by my friend Ann Sacker, who's here, and I would strongly recommend to all of you who, if you haven't read it. So the medical community was just really confident in its knowledge that cholera was caused by miasma. Basically, that cholera was caused by bad smells. And they had done these public works to get rid of all this accumulated sewage and dump it into the Thames River, that people were drinking out of, as a way to, get rid of these accumulated bad smells. And the founder of the London General Board of Health was totally on board with this thing about miasma. And this guy, this young physician and this priest ended up really trying to figure out a different way to approach it. And at a key point, when they might have given up, they were supported actually by William Farr. And he said that he had been doing his own investigations of cholera, and that he thought they were really onto something and they should stick with it. And they might not have if they hadn't had that kind of interaction, and it is specifically kind of discussed in the book as a piece of the history. So a couple things I want to say about that. First of all, that clearly what I said about counting, classification, it is how we get to public health. The second thing I want to say about it is that often the major changes that happen in our field are about some change in perspective, right? So this is what happened with DSM-3, this is what happened here. It's a different way to look at something. And so I think we need to honor, Bob Spitzer's commitment to looking at things in a different way and stay open to that ourselves. And the third thing that really touches me about the story is the generativity, right? He didn't say, oh, let me publish your results. He didn't say, oh, let me take this over. He said, good work, you're onto something, it's consistent with my data, how can I help you? And I think that's something that Bob would have done too, from everything that I understand about him. So I'm, again, extremely honored to be here, and thank you for your attention.
Thank you, Jeff, for a really wonderful presentation. We have about 10 minutes for any questions in the audience. Dr. Fernandez?
Thank you, Jeff, for a great talk. I really enjoyed it. I do think the history is worth going over, as you said. I wanted to raise the point in support, really, of your main point in the last part of the talk about the value of having different classification systems as a way of approaching an unknown and somewhat understood, but approximately understood latent construct. And I wanted to say that need, if you will, to look at the way different societies, groups, organizations, social groupings have organized the experience and the classification of disease is really something quite behind the work of any cultural approach to mental illness and global mental health, et cetera, in that they are natural experiments around the world. The cultural variations and variations across any social group, age, gender, class, education, are natural variations of ways in which the latent constructs express, and therefore ways of which to approximate, through which to approximate these constructs. And I think it's very important that we've moved as a field in the last 40 years from an attempt to see the consistency across the world that was the earlier part of our attempt to see, because it validated them as real diseases. We've moved away from that to a recognition of the need to value all this variation and assess it carefully, both within DSM and in ICD.
Thank you very much. I definitely agree.
Dr. Reeder?
My thanks, too, for the historical review, but my question is about the future and how we might, in either the ICD or the DSM-4, incorporate biological, genetic, and other biological data into diagnostic systems. That we now know that there are genes that we can associate with our disorders. None of them is so powerful that they're immediately causative. But in other aspects of medicine, they can have tremendous import with regard to treatment. And so I don't know whether they, because they're not symptomatic data, which is what we've relied on, whether they should be mixed with symptomatic data, how these have been used, and just your thoughts about what we're going to face with this dilemma.
Yeah, so that list of references that I showed, Charney and those guys, part of what they're saying is there's still no biological indicators for any mental disorder except for some sleep disorder, right? So I think it's an important question, and we all thought that 30 years later, we're still waiting for the neurobiological revolution. We thought it was coming before now. So we have said with each version, by the next time there's going to be these biological indicators. Now RDoC has said, well, you're just wrong about the constructs, and so let's kind of start over and let's proceed from the biological indicators, and then let's look at how these match up to psychopathology, although I don't think they define psychopathology all that well, and so there's a question about how it connects on the other side. I think the first place where this is going to happen is dementia, which I think is related to the move by neurology to try to take the dementia categories out of mental and behavioral disorders, which we were able to stop, actually with help from the American Psychiatric Association, and significantly. But I do think that you're going to start to see genetic and biological variants that correspond to particular types of dementia and enable their identification, enable the identification of the underlying condition prior to the onset of the cognitive syndrome of dementia. And I think that will hopefully create a pattern that we can begin to use in other disorders. But I agree that we're still some time away. WHO tends not to be really enthusiastic about doing guidelines that require really expensive assays that they're just not going to be able to do in Botswana. So we would want to see evidence that, a brain image was really, important and clinically valuable and was worth the expense before we were tell a health system, this is something that's good for you to do.
Great talk, Jeff, and thank you. Very nice for this particular lecture. I had always understood that there was a formal treaty between the U.S. and the World Health Organization that required compatibility of at least codes and terms. You didn't say anything about that.
Yeah, I did kind of refer to it in passing. But that treaty applies to all countries. So it's all countries that are members of the World Health Organization have that obligation. So it's a kind of a treaty. It's a international agreement that they will use the ICD codes, that they will be compatible. They can add more detail at certain levels, but there are other things that they can't do. WHO is, with ICD-11, WHO is going to get a little bit more restrictive and not be so thousand flowers about it. So yeah, there does have to be compatibility. Now, there's not really an enforcement mechanism, right? So what do you do if a country's non-compliant? And so WHO tends to deal with this in a sort of a hierarchical way. The most important thing is to get countries to report mortality. Some countries still don't. So we would love to get mortality data from all countries, but some countries just don't have the infrastructure to be able to do it. Then morbidity is sort of down the line. The countries like European countries are super compliant. U.S. is pretty good, so it's uneven. So even though we say that countries have to do this and that other thing, you don't really realistically have any way to make them. Right?
Yeah, I'd just like to sort of offer a laudatory comment. I've was involved for 5 years with the DSM-5 and for another 5 with ICD, and in a peripheral way with sort of sexual disorders. But I've absolutely been in awe as to the good judgment and skill set that Geoffrey has demonstrated. He had the good judgment to involve Michael in a very substantial way, which the DSM editors did not. And he's had to he's done this on a tenth of the budget of the DSM. And he's had to arrange for groups throughout the world, different nationalities, different languages, and so on, to compose and focus on these various disorders. And he's done so, have generated 300 plus articles now, publications. So it's just really an incredible contribution that you've made, I think.
Thank you so much. Thank you very much.
Question back there?
Thank you again for your presentation. So how would you recommend looking at trends over time that might have changed or been affected based on the changes between ICD-9, 10, and coming up on 11 to kind of count on changes in prevalence rather than changes due to coding differences?
So a couple things that I think are interesting to do in this regard. There are some databases that tend to be generated from inpatient settings, so the data are limited in that way. But the European Hospital Database, I think, is an awesome resource that I've looked at to look at diagnostic variation, and you could look at that quite robustly to see trends over time. There's a similar, and anybody can access it. You can get access to it online. The same with, there's a New Zealand and Australia database that's similar. They're limited by being hospital data, but you want to see how people are reporting the diagnostic codes. It's very interesting to see. The other source, of course, for this stuff is the World Mental Health Survey, and that Ron Kessler runs in collaboration with WHO that continues to add more countries, and they have way more data than they will ever be able to analyze, I think, and they, I think, are in a good position to talk about trends over time.
Okay, for our last question, Dr. Heiler.
Thank you. My question reflects my own, I guess, lack of knowledge, but is there a companion version of the comprehensive, is the CPT codes that talks about procedures that the World Health Organization does? I mean, it's nice to have, diagnostic and classifications, but what about procedures? Is there a companion version that we should know about?
Yeah, there is. It's a newer effort. It's called the International Classification of Health Interventions. It's itchy, and no, clearly not. The U.S. of course wants nothing to do with it because they're not interested in changing from the CPT codes, which the American Medical Association really controls, as you know. I haven't looked at the International Classification of Health Interventions carefully. I don't know where they're using it. I believe they're using it in Australia, but there should be a body of experience related to the application of the International Classification of Health Interventions and articles that you could find about it. I'm just not really tremendously familiar with it. There is a section on the on the WHO website on the classifications page. You can find information about that.
Okay, I want to thank Dr. Reed for giving a wonderful presentation. We have on the 6th floor of this building, there is a lunch that everyone is welcome to attend, and we'll have an opportunity for a little bit further discussion. Thanks again.